So this talk essentially is going to be focused on recurrent hernias. So that means, people that have had a hernia repaired, whether that's in the groin or on your belly or even on your flank that's been repaired and now it comes back. So I really wanted to go ahead and just touch upon the process of how we evaluate this, like why did this happen, and then kind of go over the options that people have without getting too much in the weeds in terms of the technical aspects of how we fix these. Just one single disclosure. So Intuitive is actually a company that produces the robots that we use for. Oh, is it not on? Maybe I can grab the. One second. I'm gonna grab. There's actually like a handheld microphone. I'm gonna use that. Oh, maybe that. Okay, maybe it was muted. Okay, there you go. Okay. So Intuitive, that's a company that actually produces the robots that we use for surgeries. My only disclosure is that I proctor, meaning that I help other surgeons when it comes to getting up to speed with using this technology, and I teach classes for like trainees, like residents and fellows. So nothing too crazy. This is a quick overview as to what I will be covering in this talk today. And then, of course, at the end, we'll have a session for just answering questions, anything that you guys might have. So quick introduction as to who I am, why, do you care about what I have to say? So this is my family. We actually moved here from Ellicott City, so not too far away, maybe like 90 minutes away south of here in Maryland. And where I trained was actually started off in University of Kentucky. So I was in Lexington. And the reason I highlighted this gentleman, Dr. Roth, is because he's actually a pretty well-known surgeon when it comes to hernias, and he's done a lot of research when it comes to hernia research, fixing them open. And you can honestly Google him and find a bunch of papers that he's published and I was a part of as well during my training, if you're interested in that. And then after residency, so residency was for training to become a general surgeon. So after that, you can go and practice wherever you'd like. But I chose to take another year on top of the 5 years to really do a fellowship, which is an extra 1 year of training down at Anne Arundel Medical Center. And that was with these two gentlemen, Dr. Beliansky and Dr. Park, both of them too, very well known when it comes to hernia research and hernias in general. And it's kind of where I like sharpen my skills when it comes to managing hernias and complex hernias and things like that. And then now, right after fellowship, so I graduated in 22, and now I work with Dr. Paula and Dr. Sodeman. They're both surgeons over at Hershey Medical Center. And so we collaborate on patients. There's a fellow, meaning someone that was in my position down at Anne Arundel Medical Center, that all three of us work with on a weekly basis. All right, so this is just a very quick overview as to what a hernia is. But essentially, it's when you have a protrusion or a bulge of an organ or any other part of your body wall or part of your body that pushes through your body wall, which means your musculature. And it's a pretty common condition. Almost 5 million Americans have a hernia. And then when we talk about recurrent hernias, this is typically in the setting that someone's had a hernia repair done already at that one location. So what typically happens is that people end up developing a bulge at the site of the prior repair. So it's very common for patients to say, hey, I had this area fixed, but now it's popped back out again. It can also present as recurrent pain. So, some patients may not see the bulge that's happening, but they may feel as if whatever they had fixed previously has come back because of just the symptoms. And then there unfortunately isn't really a specific timeline of when these will occur. So in general, there's early and late recurrences. So when we talk about early recurrences, that means something that's come back within a couple months or within a year. That's generally a technical error, meaning either the closure probably wasn't done in an optimal fashion, or just it was a emergency situation where they couldn't do the gold standard when it comes to the repair itself. Whereas later on, we're talking about many, many years later down the road, it could be, for a number of reasons that I'll talk about in a separate slide later on. But ultimately, what I do want to stress is if you have a concern for it, absolutely go to your, you can always go to your PCP first if it's been a while and you don't even know if your, surgeon is around in the area anymore, or if they're still, practicing in the area, you absolutely could, go back to them, get reevaluated, and then try to figure out what might be going on. So I just wanted to highlight some common misconceptions, but really these are actually things that patients have told me that I wanted to at least address and talk about with the audience. So one of the common things I always get is, mesh is the devil. It causes problems. I've had many friends and relatives that have had issues with it. And while that can be the case, a lot of those concerns probably are more, blown up now than in reality. And I'll go over that as well later in the talk. But I wanted to at least bring it out there that, mesh can be sometimes a problem, but it's not always the problem. Here's another one, once I've had it fixed already, maybe I've had it fixed once, twice, three times, the surgeon told me I'm not fixable anymore. And I don't think that that's really true. The number of patients that truly have an unfixable hernia is extremely low. I would say probably less than 1% of the population that has a recurrent hernia can't get it fixed. It's just a matter of, can we get you to the point where you're going to have a successful hernia operation? Pain means if you failed again. Unfortunately, hernia surgeries hurt. If you've had one yourself, you know kind of how that initial recovery process goes. So it doesn't always mean that it's failed, but if it persists or it gets worse as you're in your recovery period and now you're, over a year out or multiple years out, it's worth, investigating to make sure it hasn't failed, or maybe it's something else that happens. Another common misconception is when patients say, hey, I saw, this surgeon, and they said that we can't really offer a minimally invasive operation. This will have to be done the traditional way. And again, that's really kind of hit or miss. Ultimately, when it comes to the surgeons and fixing hernias, you want to do what's comfortable for you and what's going to give your patient the best outcomes. So if that means doing it the traditional way with a big incision, that's what it is. But I always, recommend, even patients that I see myself, if you are not satisfied with what you're hearing, you can always get a second opinion. Seek another surgeon just to get their kind of insight and thoughts as to the situation. And then, something that I hear also commonly is, maybe someone was doing something they shouldn't have immediately after the or after the surgery or during the recovery process. And they said like, oh, I picked up this table or I did something that I shouldn't have and it came back. Now, in general, I always tell my patients, unless you're doing some like intense weight training, like you're trying to become a bodybuilder, the amount of weight that you're lifting, shouldn't be to the point where it causes a hernia to come back. And what I mean by that is we do things on a day-to-day basis, very commonly, that probably generates a lot more force than you probably imagine, like sneezing or coughing or straining when you're going to the bathroom. There's been research studies that shows that doing that is like, you're generating well more force than like lifting 20 pounds or 50 pounds. Like it's probably in excess of 120 pounds. So it's not typically that, the fact that you lifted something or you did something you shouldn't have, that a hernia came back. There's probably other explanations for it. Because in general, for hernia patients that have had a repair, they should be able to return back to everything they want to do afterwards. I usually say like once you've, gone back past the recovery period, whether that's a month or 3 months, depending on the extent of the repair that you have, you should be able to get back to, doing the things that you want. And in fact, we've done operations on patients that ended up wanting to do weight training or bodybuilding for that matter, and or being like high performance athletes, and they have no problems. So I just wanted to highlight that. And then kind of a really common thing as well that I hear is essentially, we can't fix it. Your weight is too high. Please lose some weight and then come back when you're, below a certain X amount of pounds. And I think my issue with this is while that's easy to say, in reality, achieving that can be extremely challenging. So that is one of the benefits of how hernia repairs have advanced over the past 5 to 15 years. And in that, how we fix these hernias now, and being able to do them with small incisions means we probably can be a little bit more lenient in terms of weight, especially because we know that, losing weight is hard. GLP-1 agonists, weight loss surgery, we have more options nowadays, but, the medications are still really expensive. They do have side effects that, cause people to not be able to take them long term. And really, that's a lifelong drug. If you stop it, some people get the weight back. So before sometimes for patients that do have high risk hernias, meaning hernias that we're really worried about causing an emergency situation, within a short time frame, sometimes, we just have to do our best to optimize the patient, but then go ahead and fix it, understanding that potentially there might be a slightly higher risk of recurrence in the future, but not, that doesn't always materialize. All right, so next, kind of the big question or the elephant in the room is, why does a hernia repair fail? And kind of like I alluded to earlier, there's a lot of reasons. It's not just a one single thing that causes hernias to fail. So probably the number one thing I would say is technique. And what I mean by that is hernias have how we fix hernias and how it's evolved over the last, decade or so has really changed in terms of, how we fix it. So there's not just one single way of fixing hernias anymore, like it was, 20, 30 years ago. We have many, many, like 10, 15 different surgeries that we're able to offer patients. And it really depends on a lot of different factors that you have to take into account because every hernia is individualized to the patient. It's not just, I think traditionally people thought a hernia as a whole, I just got to patch it, close it up, and that'll, fix it long term. But we know that's not necessarily the case. And so really tailoring what operation you're doing and how you're doing it makes a big difference. Secondly, of course, weight gain. And the reason for that is actually probably a little bit more simple than you might imagine. So mesh is ultimately a man-made material. It's typically made out of plastic, polyester polypropylene or polyester. And what happens with weight gain is, let's say you put on an extra 100 or 200 pounds in a short time frame, you're adding a lot of additional stress on your belly. So every time you cough, every time you strain, anytime you sneeze, you're putting extra pressure on that mesh. So this doesn't happen frequently, but it can in the sense that it'll fracture. And that's what you're seeing in this photo right here. You actually see that the mesh itself actually looks good, but ended up developing a hole in the middle of it. And then this is actually a pretty common situation. So, hernia surgeries, or as a hernia surgeon, I would always hope and wish that my patients do not end up having to have any surgeries after we fix a hernia. But that's unfortunately not always possible. And there might be emergency situations or even elective situations where you do have to have a surgery. And that new surgeon is going to have to cut through or put a hole in your mesh. Now, it doesn't always guarantee just because they do that you're going to end up developing another hernia at that spot, but it does probably increase the risk of you developing a hernia there, especially depending on how they close it when they're finishing up their operation. So something I always offer to my patients is that, hey, we did a big operation on you, everything looks good, but if you do end up having future surgeries or you're planning on having something else, feel free to have your new surgeon, reach out to me and I can kind of give them some information about what we did and how to kind of avoid increasing that risk of recurrence after they're done with their operation. And then unfortunately, infection is something real. I know these photos are pretty graphic, but essentially what they're illustrating is that this is a mesh infection. So it's probably from a hernia standpoint, something that we fear the most because when we're talking about mesh infections, mesh is permanent. It's not going to go anywhere. So if that gets infected, you can imagine the damage it can, wreak on your body. if there's a persistent infection in that space. So one of the good things though is, especially with the meshes that we use and where we put it, is a lot of these are salvageable. And what that means is, we don't necessarily have to go back in immediately and take out the old mesh, basically undoing everything that we did before. But there are certain circumstances where that's not possible. And you can see here in this unfortunate patient that it did get infected and they did have to go back in and take it out. And ultimately, it was a prolonged process in terms of wound healing. So that can happen, but again, it's something that we really strive to minimize any risk of, because that can definitely cause hernias to come back. And then kind of the final thing, which no one likes to hear, but unfortunately, as we get older, our tissue does not stay as robust as we were when we were 20, 30, 40 years younger. So purely because of age-related changes and how our tissue evolves over time, depending on how a hernia was fixed, that can potentially put you at risk of the hernia coming back. And these are probably more commonly in people that have had a repair, let's say 15, 20 years ago, and then suddenly it just pops up out of the blue. And in those circumstances, it's not that the patient did anything wrong. It's not that the surgeon did anything wrong. It's just sometimes, even though we give a good repair, these things can happen as we age. So it's really, when we talk about hernias in general, most of the time it's fairly straightforward in terms of how we evaluate them. But when it comes to recurrent hernia, things do get a lot more complicated. So when you're seeing a surgeon, first off, they should at least get a very good history, meaning understanding all the surgeries that you've had. So I love patients when they come in with like a piece of paper and they've written down all their surgeries that they've had and what date they've had and who did it. Because it's really helpful, because a lot of people end up forgetting, oh, I did have that done, or oh, they used mesh or they didn't use mesh. So that's really important, because a lot of the times if we're trying to get like records from over 15 years ago, it's not happening. If there's just paper charts, we're not going to be able to likely get that, because either that all got shredded or it's tucked away in a file cabinet somewhere that we're not going to be able to obtain. And then, of course, once we've gathered all the history that we need, the next part is actually examining, your belly and where the recurrent hernia is. So we have a sense of like, how big is it? What sort of discomfort you're having? Can we push it back in, or does it stay out all the time? Things like that. And then, of course, obtaining any records if it's even feasible, because like I said, a lot of the times, people that have had surgeries over 15 years ago, it's exceedingly difficult, when we're in an analog age and, nothing was digitalized. So sometimes we just aren't able to get that records. But if we can't, the next step is typically getting some sort of imaging. So I put up this picture here because you can actually see this is an interesting CT scan. So this patient actually has a recurrence, and you can see this like bright white line. So that was a mesh that was placed before to fix the hernia. And you can see these little bright white dots as well, and those are metal tacks. And so it kind of highlights two things. Number one, when we get these CT scans, we can actually see the old mesh in the repair, especially if we know what we're looking for. And then number two, it also gives us some information as to how it was fixed, because especially these metal tacks, they're really pretty obsolete at this point. Not many surgeons are using these anymore because they're permanent, as you imagine, and they're literally like little screws, and they corkscrew into your muscle and tissue, so that can cause pain. So nowadays, a lot of people use absorbable tacks, so you wouldn't be able to see that on a CT scan. And then after all the information has been collected, really the next step is to talk about what your options are. Now, when it comes to hernias in general, you really unfortunately do have just two options. So you can either wait it out and just kind of monitor your symptoms, monitor your hernias, see how it's doing, or you can always go ahead and fix it. And the reason why is there's no like physical therapy, there's no medication that you can really take to address a hernia. And long term, hernias eventually get bigger. They don't get smaller either. So I know a lot of people are nervous about just waiting and letting the hernia getting bigger, which is a reasonable concern. But I would say that the biggest problem that we don't know at this point is how quickly will a hernia grow bigger. So, some people might have a hernia and it stays the same size for 10 years. Others, it might double in like 6 months. So we don't quite know why that happens or why certain patients do have hernias that grow bigger in a shorter time frame and others don't remain stable. But that's why it's worthwhile. If I have a patient that we're just going to watch their hernia, I try to follow up with them at least within 6 to 12 months, just so we can touch base and make sure that it's not getting more symptomatic or that it's getting bigger to the point where we're like, okay, we really should talk about fixing this. So when we talk about actually doing the surgery, there's really two major options. So you do have the open traditional way, and then you also have a minimally invasive approach, and that can be done laparoscopically or robotically. So when it comes to open operations, essentially they can be used to fix any hernia in any scenario. And there is, this was the kind of gold standard of repair for many, many years. So we know there's a lot of literature and a lot of data that shows that when done correctly, this is a durable repair. Now, the downsides of an open operation is when you have a big incision on your belly, you do have a slightly higher risk of infection. And that's because that big incision, you've got to essentially heal, incision that might be 12 to 16 inches long. And because of that too, you may end up having more pain and, stay longer in the hospital. Alternatively, with any of these minimally invasive approaches, typically they're shorter recovery time because even though the work that we do is typically like as involved probably as some of these open operations, on the external portion of it, they're less than half an inch each. And you may have 3, you may have 4. Sometimes people do have 6 of them, but they're still relatively small when you're comparing it to 12 inches. And when it comes to complications, we do know that that the risk of complications can be a lot lower just because we can be more gentle with the tissue, and we actually are able to see a lot better because everything's kind of up in your face, and you can identify if there's scar tissue or bowel, something that might be harder to do in an open operation. And then the other pro, which I mentioned earlier, was that with these smaller incisions, we really probably can be more lenient in terms of our patient criteria. So when we talk about open repairs, 3 things always kind of come into play. Number 1, weight. So typically, patients for open repairs generally like to be less than a BMI of 40, because we know that if people are 45, 50, higher than that, that can lead to increased complications like infection or hernias coming back, recurrence rates, things like that. The other part of it too is smoking. So people that are actively smoking, because you have to heal a much bigger incision, generally you should quit smoking, at least 4 weeks before your open operation. Now, there's been papers that have looked at whether there's an impact on smoking when it comes to doing these robotic or laparoscopic surgeries, and it actually shows that it's fairly equivalent. So whether you smoke or don't smoke, it doesn't matter as much when we do these smaller incisions. And then the final piece is diabetes or glucose control. So ideally, you want a glucose A1C of less than 7.2%. And the reason for that is because glucose, if you're a poorly controlled diabetic, that actually impairs your ability to heal. Especially when we do these big repairs, we want you to be able to heal, especially quickly after the surgery, so that the repair itself can be strong in as short as a time as possible. So if someone's going to have blood sugars in the 300 to 400s and they just don't control their diabetes very well, that's going to put them at higher risk of complications as well for like cardiac events like heart attacks, wound infections, things like that. So the downside with doing these operations though is they can be longer because with smaller incisions it can be trickier to tackle bigger hernias. And then there really is kind of a limit as to what sort of hernias that you can tackle with these. So with people that have extremely large hernias, meaning like over 75% of your internal organs are in the hernia, it probably doesn't make sense to approach it with a robotic approach because it just would take too long and put the patient at much higher risk from an anesthesia standpoint. So for those patients, they probably would be more appropriate for an open approach. And then kind of the final thing is just it really requires like experience. Like you don't want someone that's just kind of dabbling in minimally invasive surgery or robotics or laparoscopic to be tackling these larger complex hernias that have come back, because if you don't do a good repair, it's just going to come back again. And then it's going to probably make the situation worse. So preparing for surgery, we kind of talked about these key points when it comes to optimizing people. And so I said, below 40 is ideal, but we know, especially if we're doing robotic or laparoscopic repairs, sometimes we can be more lenient with that. Smoking, definitely would be beneficial just from a breathing standpoint, because all these surgeries are done with general anesthesia. So you'll be put completely under. And so people that smoke tend to have more reactive airway disease and coughing after these surgeries, which, coughing after hernia surgery is going to be extremely uncomfortable. And then, like I was saying, diabetes control, less than 7.2% is ideal for your A1C. And then depending on what other health conditions you have, we typically do have you see your PCP or maybe a cardiologist or kidney doctor if need be, to just make sure that there's nothing on their end that they need to do. And then really, I think a lot of the discussion when it comes to scheduling or planning for surgery, especially for patients that have had recurrent hernias, is just setting expectations. So a hernia that's been fixed once or multiple times before, it's going to take longer to go back in because you're going to have scar tissue. You may have old mesh that we're going to have to work around or take out. So it's going to take longer regardless of whether this is going to be done robotically or open. Typically for these bigger operations, we also use drains. So that means one of those rubber tubes that go into your body, and then that gets removed in general less than a week or so after the surgery. And for some people that have had, big scars or scars from the prior surgeries, there is a conversation to be had about, if we're fixing them robotically, we're probably not going to be able to address the scar at the same time because it would otherwise defeat the purpose of making a big incision to revise the scar if we're going to repair it with small incisions. But interestingly enough, a lot of these scars after the hernia is fixed, they actually start fading and, getting smaller as well. So I always tell people, give it at least a year after the surgery. And if you're not happy with how it looks, it's a much easier operation to go back in and revise a scar. And then in terms of the recovery process, typically it's 4 weeks, no heavy lifting over 20 pounds. And that would be whether it's an open operation or a laparoscopic or robotic operation from my standpoint. All right, so I touched on this earlier about mesh, and I know we've probably all seen these ads about, mesh alerts and lawyers looking to litigate for if you've had a mesh placed in you. So in general, a lot of one of the big questions from patients is, do I need mesh? And the overall consensus is that yes, except for one exception where we're talking about like the tiniest hernia. So usually less than a centimeter or in that 1 to 2 centimeter gray area, you can probably get away without using mesh to repair the hernia. And this is based off of, data that's been around for quite a while, over 25, 30 years. And you can see here, these are multiple studies that were looking at recurrence rates of hernias that were only fixed without any mesh. And you can see it ranges anywhere from 18% to 63%. Now, that's not very good because, if the chances of this coming back was, greater than a coin flip, I probably wouldn't recommend doing a surgery for my patient if I knew that was going to be the recurrence risk. And that only gets compounded if they've had prior repairs, meaning you've had it repaired once already, it came back, and now you're going to go back again and repair it again without mesh. That's only going to increase that recurrence rate risk. And then these are some additional studies that came out of the Netherlands. And basically, they're just looking at the difference between patients that had their mesh or that used mesh with the repair versus those that didn't. And you can see this is like a 3-year mark after surgery. And people that had mesh was about half of the recurrence rate compared to those that didn't have mesh. Now, granted, this study was probably in the early 2000s, so these rates are still fairly high for me. And then they kind of looked actually longer. They looked at a 10-year mark compared to the 3-year mark. And you can see that gap was actually got wider. So, 32% with mesh ended up having something come back, whereas 60% that only had suture repair ended up having the hernia come back. But granted, that's older data. This is probably a little bit more recent, although it's still, 10 years old now when this was published. So this came out in 2016, but you can see all these different modalities of fixing hernias. And they're looking at a 7 to 8 year time frame. And so at the end of that time frame, you can see that not using a mesh ended up with the 18% recurrence risk. Whereas if you do laparoscopic surgery with a mesh, that was almost, cut in half, closer to 11%. And I think as things have evolved, even since 2016, our recurrence rates are usually, less than even these numbers that are reported now. It's probably closer to less than 5% at this point. And so this is kind of a nice diagram because I think for patients, it's always a little confusing as to where do we put the mesh. So this is a cross-sectional view of your belly. So these are actually, these circular or oval red things are actually your ab muscles. So typically when we have a hernia, so that's imitating the hernia, when we fix the hernia, we're, closing it off, repairing the hole, and there's multiple locations that we can put a piece of mesh. So you can see all these blue lines that are going to pop up. That's where we can put them. So we can either put them on top of the muscles, we can put them underneath the muscles, or there are two other locations. We can put them another layer deeper, or put them actually inside the belly, where it comes into contact with your internal organs. So nowadays, we try to highlight or do these repairs where the mesh is actually outside the belly, because we know when it's inside the belly, it'll cause scar tissue to form, it'll potentially erode into bowel, and really cause some big problems that we don't want to happen. So by tucking it in underneath the muscles or below the muscles, you minimize that quite a bit. So let's say you've had a hernia repair and now you're just interested in how do I, prevent this from coming back. So there are a couple things that you can control. And so of course, weight management is going to be one of them. Don't put on like 200 pounds. That's going to put more stress on the repair. And then other lifestyle habits like smoking, safe lifting habits. And then the reason why I put on avoiding constipation is you can imagine if you're straining, on a daily basis all the time, you're just stressing that repair constantly. And over time, it may end up leading to a recurrence. So I always tell patients, try to target for 1 bowel movement a day where you're really not straining, and that should be normal. And then immediately after the surgery, things that I do recommend for patients are a couple things. So number one, just because we fix everything and put everything back together, it doesn't mean that your muscles don't need strengthening. So what I always recommend is people go to physical therapy if they need help, like understanding good exercises to do, or if they're comfortable, doing some exercises themselves at home, because a lot of these things can be done with minimal equipment, so you don't necessarily need to go to a gym to strengthen your core muscles. And then for patients that are more physically active and they want to get back into exercising, really the big thing I stress is just kind of ease yourself into it. Don't, immediately after the lifting restriction period, jump back into 100% effort, because you're probably just going to end up hurting yourself if you do that. So I always tell people start off at about maybe 50% effort, 50% of what your normal weight or your reps are, and then ease back into 100% over the course of a couple weeks. So this is my last slide, but in summary, hernias are really common. So with it being a really common condition, unfortunately, that does mean recurrences also do happen. I think it's really important, especially with recurrent hernias, to do a really thorough evaluation to make sure that you're not missing anything in terms of what surgeries they've had or what you might anticipate if you were to go back in. And when we talk about recurrent hernias, I do strongly believe that they probably should be evaluated by someone that does them routinely. Doesn't have to be me, but it should be done at least by someone that fixes complicated hernias or sees a lot of these hernias in their practice, because I think that'll ultimately lead to better outcomes long term. And then kind of the final things are, know your options. So like I said, just because one surgeon says, hey, I can't offer this option, it's worthwhile to, always get second opinions before, especially when you dive into a complicated repair when we're talking about recurrent hernias. And then kind of the final thing is, I've had surgeons or attendings that I've worked with in the past, and hernias, they're not typically like cancer or something that'll um uh like cause you to die, but they do cause significant like daily lifestyle issues. And so I think that weighs on people a lot more than they think. So um, it's easy to get kind of discouraged if you get turned down for an operation in these settings. So I just want to, let people know that you do have options and that it's worthwhile to find someone to at least be reevaluated if you've already been turned down a couple times. All right. And that's it. That's all I got. Anyone have any questions? Or, oh, sorry. Mhm. Yeah, so this is gonna kind of be silly, but when it comes to bowel movements and like medications to address constipation, I think it gets a little confusing because you have obviously stool softeners and then you have laxatives. So stool softeners should really be used for patients that already are going like pretty regularly, like maybe every day or every other day, but it's just hard to kind of, you're straining a lot basically. But if people are actually truly constipated, meaning they've gone a day or more than 2 days without going to the bathroom, taking a stool softener is not going to help. You could take a bunch of it, but it's not going to actually help you go. So that's when you actually have to take a laxative. So that means like milk magnesium, magnesium citrate, one of those medications. And the good news is you really can't overdose on a laxative, because if you've ever had a colonoscopy, they have you pretty much drink a whole bottle of it. So it's going to work when it obviously starts running through you, and you can start backing it off. But in general, though, you can start off slow with like, a dose a day or 2 doses a day of like Miralax, and kind of work your way up until you get the results that you need. Yep. Anything else? Yep. Mhm. Yeah. Yeah, no, absolutely. So, it's not uncommon where I've had a patient say, "Oh, I had the left side fixed," but then you get the CT scan, it was actually the right side. So you can see evidence of prior surgeries, because it usually leaves a trace of like scarring, or if you're looking for mesh, if it was used at that point. So you should be able to see where the surgery was performed, and then how they did it in the general sense. Like I won't be able to tell you the exact like brand of mesh that was used, or um but when it comes to actually understanding like how it was repaired and where it was, you can absolutely tell. Yeah. Cool. Yeah. Hmm.
My spouse is treating that like one of the things men. My lifestyle.
Right.
So I'm in the watchful waiting stage. I don't have a recurrent hernia.
Sure.
It's produced and well supported, and I
Lift heavier.
my normal stuff.
Yeah.
Like 50.
No, absolutely. I mean, especially if you wear, they have those inguinal hernia belts or trusses that you can wear. Um, I usually recommend for people just first thing in the morning, put it on, because usually as you're going about your day, it tends to pop out more. So first, if you put it on first thing, it keeps it kind of tucked in and not popped out. So it is going to be at least a little bit more comfortable. Yeah.
Yeah, I'm doing that.
Okay. Yeah. No, absolutely. Yeah. Sorry.
Pain is a subjective thing.
Correct.
And can you give some sense of the thinking between sensation, something that just simply keep you happy and all the rest,
Yeah.
versus the contradiction itself?
Yeah. So I think it depends on the type of hernia. For one, like inguinal hernias, they can be more uncomfortable. Like a lot of people just say it's more so bothersome than pain. But for certain like belly button hernias, they could be completely no pain, no issues at all. But then one day it just like swells up and starts causing like really sharp pain. And a lot of the times this is pain that will double you over, and you end up having to go to the emergency room, or essentially you're kind of out of commission for a couple hours. And so that's the type of pain when I'm talking about like pain related to the hernia. But if but some patients, it'll start small and then gradually get worse and worse and worse, or they just notice it more, like if you start bumping into it more as it gets bigger, and or someone's like, parents with children, they get kicked in the hernia, and then it really kind of sets it off. So it is subjective in the sense that everyone feels pain differently, but I would also say it's subjective in the sense of like what's your level of threshold that you're willing to tolerate before you're like, hey, I should probably get this fixed. Yep. Um, so IBS, no. IBD, like Crohn's and ulcerative colitis, do, because unfortunately for those patients, they do end up having prior surgeries before, or they have an ostomy. And the other part of it too is with it being an inflammatory condition, you do tend to have a much stronger reaction to surgeries compared to other patients. So I think you have to have a higher suspicion of it being a little bit more treacherous if you're going to go back in to fix a hernia with someone on that history, because people end up having much more scar tissue as a result. Any other questions? All right, cool. Well, thanks again for everyone for taking time out of your schedule to come here. I'm gonna hang around. So if you have any like personal questions that you want to come up and ask me, I'll hang around and be happy to answer them. All right, thanks.